Ladies and gentlemen, thank you all very much. The hour of 2 o'clock having arrived, we're going to call this meeting of our board's Health and Hospital Committee to order. We will begin by turning to the clerk and asking the clerk to call the roll and establish the presence of a quorum. Here. Thank you. The presence of a quorum having been established, we will move then to public comment. Public comment is that portion of our agenda set aside for comment on non-agendized items properly within the jurisdiction of our committee. And again, if you are here to speak to an item that is on the agenda, we would ask that you address us at that time. Public comment, we do have two cards today, Scott Largent and Lindsay Austin. We'll ask you both to come on up, and we can provide up to 3 minutes for each of you.
Ready when you are, Colin. Appreciate it, bud. Thank you. Good afternoon, everybody. Scott Largent. I took a quick break right now from Susan's over there at criminal court, Susan Bassey right now, the one that's being prosecuted over filming police misconduct in a courthouse when I was being harassed and held in an actual chair in front of a computer. I didn't realize you weren't able to take a photograph, a screenshot of a computer. You know, it's Silicon Valley. I just did not realize that you're not allowed to do that. So when you come across documents and places, I always take a picture, scan things, you know, create my own records. It's easy to do with my smarty phone, Note 9. This thing's great. We can't do that in our courthouse. And if you do it, you get prosecuted. It's just sad, the dog and pony show that they're putting on and what they're doing to her right now. It drives most women that have been through divorces here in Silicon Valley, it just drives them to the edge. And I ran into that with Pam Noodleman that I met. She was married to a district attorney, a prosecutor. It's kind of all the same thing. They all dealt with this Bradford Baugh, and he was an attorney that just destroys women here in Silicon Valley. And we're getting a lot of those women together, and they're fighting back right now, and they're just fed up with this crap. But the other problem is they're ending up out at Elmwood, and they don't have criminal records. They're being charged with contempt. They're being prosecuted for just speaking up, standing up for themselves, and it's really sad. And I'll tell you something, Susan's gonna tear this whole thing down. She's been doing records requests. She's been basically pulling the pants down on the county and figuring out that this thing is just an absolute wreck. A lot of what I talk about coming in here, to just kind of switch topics right now, I tried to come in here and explain my story, what happened to me, what I thought the county could do better, my feedback from being a recovering drug addict. And I've been sober now almost 3.5 years, and I don't think any of my concerns or complaints or anything I talk about have ever really been listened to. I talked about the different types of methamphetamines that are on our streets, okay? I talked about the old school biker meth and that stuff right now that's making all these mentally ill homeless people go absolutely batshit nuts. Pardon the language, but they are going crazy out there. And we see in the news right now that poor gal Bambi got basically beat to death by a homeless transient that we could not do something about. We could not put that guy on an EMS hold or put him somewhere. He was busted with a meth pipe. They weren't deporting him. There was all these things that the system failed, but we did nothing about it. I put more videos up online. You've got a methed out crackhead on the other side of 87 right here. That's barbecuing, he's putting these banners up, he's doing all this crazy stuff out there. He's been going on 5 weeks of doing this out there right now. No law enforcement has gone over there, no one's cleaned up the area right there, no one's offered this guy services. Is he gonna go beat someone to death next because you people aren't doing your jobs? Thank you.
Let me call Ms. Austin, who is our next speaker under public comment. Good afternoon.
I came here yesterday and spoke to the Board of Supervisors meeting. I just got out of a meeting with my attorney this morning, still attempting to resolve the issues with DCSS.
Ms. Austin, I apologize for interrupting, but I can barely hear you, so I'm going to stop the clock so we don't use up any more of your time. Ask the clerk to make sure the volume is up so we can hear you.
Okay.
Colin, do we think we're good? Okay. Go right ahead. Sorry again.
No problem. I was here yesterday morning speaking to the Board of Supervisors meeting, still trying to figure out the difficulties with DCSS getting me my spousal and child support for January, February, and now March. Had to apply for food stamps yesterday because of that. women going through divorce, women facing sexual assault, and just vulnerable women in this community in general are vastly underserved. Despite having a restraining order and reporting a sexual assault that occurred late February 2017, I was denied Cal VCP funding despite having a letter from my forensic neuropsychologist, Dr. David Dahl. Did a hearing, and it was all based on the police officer's assumption that I was only reporting the sexual assault because I was the one that got taken in and processed endowment with assault charges for trying to defend myself against my assailant who had broken into my home. I also witnessed a young woman visiting from England who was brought to me by my friends after being sexually assaulted in San Jose. She had no pants on. She had been drinking, and she ran to someone's house and called the cops. The cops dropped her off at a motel and asked her if she regretted anything she did the night before. I called the EMTs, and she was taken over off of heading to the hospital over there, and the SART team did a full examination of her. She had tears, she needed medical attention, and she was not given appropriate treatment even there. There was nowhere they could refer her, no services for her. So it's just a big problem, and it would be nice to see more resources. It'd be nice to see appropriate response by the police, especially as I'm getting threats to my life on my cell phone. And they told me that I'm an adult, I can handle my disputes by myself. So, thank you.
Thank you. Let me just confirm with the clerk that we have no other cards under public comment. We do not. That takes us then to item number 3, which is the consent calendar. And Supervisor Ellenberg, if you are prepared to offer a motion to approve the consent calendar, this would be timely.
Move approval.
Motion by Ellenberg, second by Simidian. No cards on the item. Without objection, consent calendar is approved. That takes us to item number 4, which is to approve appointments and reappointments and privileging actions of specified medical staff and allied health professionals at Santa Clara Valley Medical Center for the month of March. There's some familiar faces, but why don't we ask you to just reintroduce yourself for those who do not know you.
Good afternoon, Board of Supervisors. Thank you for having me here today. My name is Yvonne Karanis, and I am the Enterprise Medical Staff President. I have with me also Minesh Bimani, who is the President of the Medical Leadership Council at O'Connor Hospital.
Well, we want to welcome you both, but particularly pleased to see folks from our now expanded operation, so welcome. And anything you want to share with us before we ask for a motion here?
I'm here to present the credentials report, and I just want to point out that this will be the last credentials report that will come from the Medical Executive Committee at Santa Clara Valley Medical Center. This was approved prior to the acquisition on March 1st, and henceforth going forward, the reports will come from the Enterprise Medical staff.
Great, thank you very much. Supervisor Ellenberg, a motion to approve?
Move approval.
And we have no cards on this item, so I will second and say without objection and hearing none, approved.
Thank you.
Go forth and do good work, okay?
Thank you.
Thank you. That takes us to item number 5, which is to receive the report from the Santa Clara Valley Health and Hospital System relating to community-based organization health clinics. So I think we're going to get some new folks coming to the table. Yes? No?
Yes, if we could have Alice Nagby-Mugler, and I know Dolores Alvarado, and some of the clinic CEOs. I know they might be here. I know I see Ken Graham, obviously in the audience. There might be others in transit.
Mr. Graham, do you know if others are just on the way and just haven't arrived yet? All right, well then, rather than start without them, if people can be a little bit flexible, how about we go to item number 7 and receive the director's report relating to emerging issues regarding the County of Santa Clara Valley Health and Hospital System, starting with 7A from the Chief Executive Officer at the Valley Medical Center, and that would allow us to make some progress.
Thank you, President Simidian, Supervisor Ellenberg. Most of my report will come under the hospital integration status report. That is item number 6 on the agenda.
Okay. And then anything from the Director of Behavioral Health that we should hear? Okay. see if there are any questions from Supervisor Ellenberg or from myself. Supervisor, I'm at 7B here as we try and be a little flexible on the schedule.
That was quick. Just give me, if you don't mind, one second to find my right
Sure.
place here.
Let me just ask, Ms. Tullis, I think we're waiting on a report on the sighting of a North County headspace. Yes, does that sound familiar?
Okay.
Okay, yeah. No, got it. Thanks. We are working on that, Supervisor Simidian.
Can we get it in time for our April meeting of this committee?
I don't believe so. It's a fleet and facility working with our team to do that. So I'm not sure that they'll have something available for you within the month.
I'm going to turn to Mr. Santiago and I think the county exec is on his way, and say really would like to have the report. This has been years of conversation. I understand the difficulties of finding a site in the North County. I know the area well, having lived there for 50 years and served it for 35, but it's time. And it's time. So not sure where the logjam is coming from, but I'm going to agendize the item for April, and I'm going to ask for a report at that time, and we'll see how that goes.
And perhaps we could have fleet and facility here as well.
Good. So I will turn to my staff. I see Mr. Haskell's here in the office, and Ms. Helma Tincher in my office, who's worked on this issue as well. And we'll ask the county executive to be sure that fleet and facilities can be here with us for that report. As I say, it's been a long time that we've been having this conversation. So, still on 7B. Ms. Ellenberg, anything on 7B?
Thank you. Just a couple of comments. And in addition to all of the work that's underway on the hospital integration, I really just want to take a moment to appreciate that this month's report highlights some significant accomplishments to assure that our system is focused broadly on health, promotion, innovation, and inclusion, and particularly the recognition of VMC as a baby-friendly hospital and on the state C-section honor roll. I didn't know that was a thing. Really underscores the important work in our system to assure high-quality care for moms and babies, which, as we all know, is so critical for long-term success in families. And I'm also excited to see that the Gender Health Center has opened, which provides comprehensive and inclusive space to serve transgender, non-binary, and gender-diverse patients. Can you tell me a little bit more about how the center is being promoted to the community, and in particular youth and young adults that might benefit from those services?
Thank you, Supervisor Ellenberg. The first thing I would share with this committee is that we've been working with the LGBTQ Office of Affairs to schedule a community event, and that right now is scheduled and looking like it's going to be on April 6th, coming up here very shortly. And so we expect that to get additional outreach and attention to the community about this important clinic. In the meantime, our staff throughout the system are sharing the availability of these services, not just in ambulatory care, but other settings as well throughout the community.
Are you connecting through school districts?
I will follow up with my staff to determine whether or not we've reached out or have representatives on the planning committee.
Okay, that's a terrific way to reach lots of young adults, teenagers, as well as staff there too.
We will follow up on that.
Thank you. I've just one other point that I'd like a little bit more information on. As we adapt the HHC format and aim to balance continued work around the hospital integration and important work continuing across HHS, I'm interested in your recommendations on structuring this report that you make going forward that might highlight key emerging issues in each of the departments, or to frame collaborative projects that might cut across HHS departments. For example, multidisciplinary approaches to issues such as opioid abuse and overdose prevention, which could have components in VMC, EMS, behavioral health, and public health.
Supervisor, so I just want to clarify kind of going forward how we will be providing reports to this committee.
Right.
So at this point in time, obviously, we're going to have the transition report, which is really going to speak to how things are progressing, given the volume of work and work streams that we have in operation. At some point in time in the near future, we will then focus on each individual operation of each hospital within the director's report. So you will see elements of metrics, performance indicators, but also operational issues and concerns that we may want to bring to this committee from each hospital. At some point in time, and as we progress through this, we'll be working with our other departments, public health, behavioral health, EMS, to ensure that whatever identified issues we have, that we collectively work together and provide that within the director's report in terms of issues, but also solutions or recommended go-forward action items.
Did you have anything you can share about impacts of the strike yesterday?
Sure, I would be happy to. I'd also include Dr. Smith and Miguel Marquez, who was the countywide strike coordinator in this conversation.
Ms. Ellenberg, I think we're going to take that up under item number 6 here on the integration list in just a moment.
Okay.
If we're going to ask you to hold that portion.
Absolutely.
Okay.
Yes, thank you, Supervisor.
And on item 7, what we're going to do is finish up B. I have a request of the county exec I'm going to make in just a moment, but I do have a card for Mr. Largent on item 7. So, Mr. Largent, if you'd like to speak now, this is the time. Come on up.
Good afternoon, everyone. Scott Largent. With the cameras that I have, my GoPro and my Smarty phone, I film a lot of stuff around our county. I also film when people are having mental health crises. And I try to kind of keep at a distance. I try to kind of get in there sometimes. I respect law enforcement and let them do their duties. A lot of them are very familiar with me now. Actually, every single one of them knows me. I was filming out in front of our district attorney's office a couple of days ago. And Tony, this video's up online, and a gentleman is having a severe mental health crisis out there. Okay, he's been showing up to this complex here for the last 2 weeks. He's been stopped 6 different times out in front of there. Okay, he's also had his pants down past his ankle. He keeps using the N-word, the F-word. He's saying every derogatory thing in the world. He's talking to himself. He's spinning in circles. We had 6 investigators on him. We had to call the sheriff's department out there. He was having a mental health crisis, and he was also having a really bad meth addiction problem. The district attorney's office, they do not have crisis intervention training to be able to handle these people, okay? They don't have it. And these clinicians or these, the dispatch to send these people out, they're non-existent. Because where I'm filming, Tony, your people aren't there, ever. So I don't know if this is rolled out now, but I consider it a failure. This young man out there needed our help, okay? And you know what they did? They called his grandmother. Okay, they called his grandmother. This guy was a threat to himself, the community. He's been on meth for a really, really long time. Now, yesterday, he was down there fighting with the ATM machine downstairs, okay? He doesn't know what planet he's on. But people like this that are strung out on meth, moral compass just goes out the door, and this guy doesn't know what he's doing. And you see what's happening in the news now. Mentally ill, homeless people are killing people in our community. Put these people somewhere to get them help. We need to start locking them up. Thank you.
Thank you. Before we go back to item number 5, and I apologize for bouncing around on the agenda. Before we go back to item number 5, Dr. Smith, while you were, I think, out of the room multitasking, I know, I asked a question about a report on Headspace that we've been waiting for under 7B. Ms. Tully's indicates that Facilities and Fleet is part of the bundle of folks who are working on this, and that we still need to hear back from them. I just want to indicate, I'm sure my frustration is both showing, and you can hear it in my voice. This, working with Headspace to provide what I am told is an innovative approach to healthcare for teens in particular, is an issue I've been working on for more than 3 years. I believe the first commitment of funds from the county was a function of an inventory item I did in June of 2016. So we are getting to the point where that inventory item, which was designed to ensure that services could be provided in the North County, it will be 3 years this June, and we're still nowhere. That may be harsh. We're somewhere along the path to somewhere, but we still haven't actually been able to deliver anything. To put a more positive light on this, at a much larger level, when Headspace approached our behavioral health team, they too embraced the notion, and significant funding has been provided, and we're making progress on other fronts. But what I've asked is, and Dr. Smith, I'm going to ask for your help specifically, that anybody who needs to be in the room, and I mean anybody and everybody who needs to be in the room to help us make some real progress on this, be in the room at the April meeting, and let's go. It's 3 years. That's a long time to say, gee, it's tough to find space in the North County. So, Dr. Smith, I just want to ask for your assistance with that. Don't want to belabor the point any more than I already have today. If you'd like to comment, feel free, of course.
No, we'll be ready in April.
Okay, and I'll look to my team, Ms. Hellman-Tincher and Mr. Haskell, both here to make sure that we work collaboratively to get everybody in the room. All right, then we're going to move back to item number 5, which is to receive the report from the Santa Clara Valley Health and Hospital System relating to community-based organization health clinics. And I'll go back, to, I think, to Mr. Santiago, and now he can invite everybody up to the table, and I believe everybody's here, and we're good to go. So, Mr. Santiago,
Yes,
walk us through this, please.
And good afternoon, Mr. President and Supervisor Ellenberg. I have with me today, this afternoon, Alice Knuckly-Mugler, who's the interim director for the Office of System Integration. She's there in the middle. We have our Community Health Partnership CEO, Dolores Alvarado, who's to her left. And then on the other side, we have Amy Carta, who's the government relations for our team, and it was very involved in both the waiver as well as the early development of PCAP. What we wanted to do, and we have a very extensive written report that gives you a lot of history and as well as a comprehensive snapshot of a variety of different things given the policy landscape. I'm just going to cover the highlights, and obviously if you have some very specific questions to anything that's in the report, I know Dolores also wants to give the perspective, the experience from the community clinics, and so we allow that as part of the presentation, and then of course any additional questions that you may have along the way. As you know, our community clinics are indeed part of our safety net partnership. We consider them what we call our core community partner. They have historically, alongside with VMC and the VMC clinics, provided services for the low-income, Medi-Cal, and uninsured in our community. What we've organized this report is around 3 major phases. We'll call the pre-ACA. This is before national health reform, to give you a little bit of a perspective on what historically has occurred here in this county. We'll also cover what happened during ACA, because I think our board has been a big leader, not only in advocating, but also in the implementation of national health reform here in Santa Clara County. And then, of course, what we call as post-ACA, which is post-November 2016, where we had efforts at the national level to repeal and replace. We share a lot of common goals with our community partners. They've been, along with others, been big partners to expand coverage for the population that are uninsured in this community, and they provide the care as well as the advocacy related to that. They're particularly situated in low-income communities with high concentrations of underserved to provide primary care access. And I think that's one of the things that we've enjoyed in terms of this particular partnership, that they're there to provide preventive and primary care. And then, of course, they're a partner of us in terms of improving the overall quality of care that we provide to residents. Next slide. Before ACA, which is before 2014, which is when we had the major expansion in Medicaid, our county provided generally about $3 million direct general funds to our community clinics. And this was part of an effort, quite honestly, to provide 2 things. One of them subsidies to community clinics as well as VMC so that they can provide direct services to residents in our community. At the same time that we advocated and implemented universal care programs, which I think you heard several times in terms of our role in the Healthy Kids initiative as well as other initiatives. Similar to VMC, they have an ability to pay sliding fee scale for the uninsured, depending on their income. That's part of what we do in order to provide access to care, to make sure that financially there's not a barrier to delivering care and service to the populations. I believe 5 of the 9 partners are actually full-fledged federally qualified health centers. That means that they get cost-based reimbursement for Medi-Cal populations that are directly provided. The general policy under that at the federal level is that if you have a disproportionate number of Medi-Cal and uninsured, that you'll be provided funding in terms of cost, what it costs you to take care of that population. And then, of course, leading up to 2014, they were a partner for us in what we call the Bridge to Reform, specifically the Low-Income Health Program, where this county expanded coverage for adults, primarily single adults, that traditionally have been covered by Medicaid in anticipation of the major Medi-Cal expansion in 2014. As a result of that low-income health program, we covered about 13,000 residents in our community before 2014. 10,000 of them were assigned to VMC in terms of primary care, and about 3,000 were assigned to the community clinics. Next slide. Now, during the implementation of ACA in 2014 and 15, obviously, the expansion of Medi-Cal occurred. A couple notable things that I think it's important for us to keep in mind. That did not come necessarily without a cost to the county. At that point in time, at the national level, President Obama, wanted to keep the cost of ACA under $1 trillion, and therefore he asked, particularly public hospitals, to take a cut in disproportionate share hospital payments in order to provide and expand coverage for the population, not only through Medicaid, which is the national program, but also through the exchanges, in this case, Cover California here in the state. Secondly, Governor Brown, then Governor Brown, insisted that if he was going to expand Medi-Cal in the state of California, that counties had to share in the cost of expanding care, and therefore counties, through realignment, were asked to provide funding to the state, given that that funding traditionally would go to the low-income indigent care populations in those counties. So the exchange was that the Governor Brown said, I'll take money from counties, I'll expand Medi-Cal, and in exchange you'll benefit because you're going to get, for those particularly the running public hospitals, reimbursed from federal and the state for serving the Medi-Cal. The theory did indeed work out because, as you'll see later on, we did have a huge surge in Medi-Cal in this county. I think, President, you mentioned in your State of the County about 125,000 residents were actually covered under the Medi-Cal expansion, which had obviously a big impact not only for those individuals but our communities. And then, of course, there was a corresponding increase on the Cover California for those that could afford individual coverage. We created, in partnership with the clinics, what we call our Primary Care Access Program for the residual uninsured, those that remained uninsured that would not qualify for a variety of different reasons, either for Medi-Cal or the Cover California, but were also low income. And so we developed what we normally call PCAP for people that are below the 200% of the federal poverty income, so that in fact we can provide the same kind of standard access as well as the benefits that were enjoyed by the Medi-Cal and the Cover California patients. Another note for PCAP is that it's really intended to just be with our community partners. So it's not universal access. It's really intended to provide access to both our community clinics as well as VMC clinics and obviously our hospital. And then the other significant piece that happened during this period is the negotiation of what became known as Medi-Cal 2020 waiver, which is a federal state county partnership to drive some of these care delivery reforms, not only within our provider community, but then also in terms of providing better care and service to high-risk populations. And so one of the things that we did at that point in time going forward is that we engage our community clinic partners to be part of this demonstration project and extending some funding under that program. Next slide. So just a couple of slides here. As mentioned, both the community clinics and our VMC clinics saw a huge expansion and conversion of previously uninsured into now being Medi-Cal. And that was both beneficial to our clinics as well, obviously, to VMC, because those patients carry revenue associated with them. And as you know, we've been reporting to our Health and Hospital Committee on a monthly basis that VMC, because of its readiness, the hard work that's going on, as well as the investments that we made in technology and other facilities and other things, we have been able to enjoy not only being able to provide better care and service to the community here, but then also give back to the general fund. And then, of course, most recently, as you know, during the mid-year, since it's very timely, there was about another $45 million that was given back to the general fund. And I think that's so important in terms of the shared benefits, shared risks that we have, not only as a county, but also in terms of the partnership with the federal and state government. Correspondingly, we saw a drop of the uninsured more prominently within VMC because it's usually around hospital and specialty where we see a huge drop there, but also correspondingly our community clinics saw a drop on the uninsured. Going forward, what's so important as part of the care reforms is that the theory is that not only will you enjoy from the expansion of Medi-Cal, but that at least in the state of California, 85% of the Medi-Cal is actually in managed care. So we're a state of California that really believes and implements managed care, not only for Medi-Cal, but also Cover California. So the retention of those lives within our system is so critical. And I think, President Sabinian, you've noted, and we actually have booked for April as well, a further in-depth discussion in terms of what this means, because as you can see in this chart, at least looking at the VHP enrollment, just strictly the VHP enrollment, not necessarily the other plans in terms of FHP or Anthem Blue Cross, but at least on the VHP side for select years, you can see that there was an increase in both, but obviously a trending downward since the height of in 2017. And I think that's something that we looked at very closely because, of course, not only does it mean very specific things related to the population, what might be going on related to the needs and changes in that demographics, but then also in terms of the revenue associated with both our public hospital as well as our community clinic partners. Next slide. Now, as part of the waiver, one of the things that was negotiated in 2015, and I share this with our community clinics, is that we were negotiating with the Obama administration in 2015. In 2015, we had a favorable not only policy but also economic market situation. They were very supportive, of course, of public hospital systems and community clinics, and they wanted to incentivize our providers to do very specific things. So all the waiver funding is linked now to very specific performance requirements. That is not necessarily based on grants and is not necessarily just based on your cost, although there are some elements like FQHCs, they're still tied to the cost, but it's really linked to achieving and earning funding by meeting some very specific quality, utilization, or outcome requirements. And so one of the things that we negotiated with our clinics, and these are very complex things, it takes a while for people to kind of understand it, and then once you understand it, to be able to operationalize it, is that we incentivize our community clinic partners to put in what previously had been grants to actually align them to these federal requirements so that, in fact, we can grow our capacities and be able to serve more patients, be able to provide greater access to both residents and communities in Santa Clara County. So in this snapshot, what you see here is that we are presenting what each individual clinic contractually we negotiated with in terms of the maximum financial obligation, which is the total contract amount that's available, if indeed it's earned. That is, you got to meet these very specific requirements. And then, of course, what's been the traditional experience, at least for 1 year here, 1 full year or fiscal year 2018. And as you can see, including VMC, this is something that is not just particular to the clinics, it's not expected that you meet 100%, because these are supposed to be things that you're reaching for, you're striving to accomplish. And of course, the experience is that if you accomplish 80% of it, 90% of it, and you provide improvements, that's actually a good thing. You're on your way to delivering not only better care and better services, but ultimately achieving the outcomes as a result of those care delivery reforms. So you'll see this experience very not only with our community clinics, but also with VMC. Were there questions, or do you want me to take a pause here? Or
no,
do you want
it's
to
all
just
right. Why don't we?
continue?
I think you're
Okay.
close to the end there somewhere. Yeah.
Yes.
Why don't we let you finish up then?
And then, of course, the next slide, I think our clinics, I think Dolores has a presentation. I don't know if you want to do it now, but these are bullet points that from their experience they share with us in terms of the Community Health Center and the whole person care and the global payment program. Those are 2 specific initiatives. I don't know, Dolores, if you want to hold off or say something at this point.
I will hold off.
Okay. But at least this is what they have shared with us in terms of obviously trying to build a system of care and the challenges and what we need to do going forward. And then the last quote that we have here is Alice, who Alice has been a tremendous leader for not only our nurses at VMC, but the VA system dealing with high-risk populations, and she was very gracious in stepping in as an interim on the Office of System Integration. And we borrowed a quote from you, President Simitian, in terms of what we're striving for, because I think it's so important that we keep that in mind. And Alice, if there's certain things that you want to add at this point.
Thank you, President Simitian, Supervisor Ellenberg, and the rest of the team. I think the main issue that we're striving for is collaborative work. This is very difficult work, I think, is one of the things that it's related to regular and frequent reports to the state and work that takes a lot of time and energy to develop. And so the collaboration that we have together to work together has been very helpful in this process. I would say we're also learning. We are, this was a new ballgame for us. We've really conceptually changed the way we do care to look at our high-risk patients and determine in both the PCAP and the GPP program, as well as the whole person care, the goal is really to reduce hospital admissions, ED visits, urgent care visits, and establish a primary home, health home for each of the patients. That's not an easy feat. And it takes time and energy to do, and it takes time and energy to bring the staff along in changing their conceptual framework from episodic care to coordinated care. So that's a change. Fortunately, the community clinics have been well positioned by the work that they've done to become health homes, so they have done the groundwork to do that in many instances. But I think the most important thing is that we are really working towards a value-based operation as we move forward for all of us. We have to meet certain targets. If we don't meet them, we won't get reimbursed. And that holds true for all of us, both the hospital and healthcare system, as well as the community clinics.
Thank you, Alice. That concludes our presentation. Obviously, if any questions you might have, we might answer.
Thank you. I do have some questions, but I'm going to defer to my colleague for a moment. But I wanted to offer some comments about why this item was agendized the way it was agendized and the kind of conversation that I hope we're going to have today. And as I mentioned at the last meeting, the restructuring of the format of these meetings is designed to try and facilitate what I'm going to call a real conversation. Or as a friend of mine once joked, I went to a meeting and a real conversation broke out because this is not a format that typically really facilitates that. We go up and down the row, we ask everybody for their 2 minutes, people come up and present for 2 or 3 minutes. And so rather than perpetuate that kind of a non-conversation, the notion was, could we pick a couple of areas that were of importance to the organization, sit and have the conversation. Now, I know that's hard to do in an open space, and particularly if you've got a board member, or maybe even two on some days, who are grumpy about a particular issue, as I was today about a particular issue. But as I say, I really do think we need to have these conversations. We particularly need to have these conversations on this topic where we are working with community clinics in, I think the term that was used was a collaborative way, or at least we aspire to work with them in a collaborative way. Many of the clinic folks have reminded me of the repeated use of the word partnership from my State of the County remarks last year. My own view is that we have in place, and I think we're very fortunate to have it in place, a combination of county clinics and community clinics that, working together in tandem, really can provide extraordinary service, and do, across the entire county and across the range of folks we're trying to serve. It has struck me, however, during the past 6 years that I've been back on the board, that the relationship seems somehow scratchy almost always. And I don't say that critically, I just say it matter-of-factly. It's like, okay, if we're all partners in good works, shouldn't that be a source of constant celebration? And maybe it is, but it seems to me it is certainly almost always a source of tension. Now, maybe that's a healthy tension, maybe it's a necessary tension, but I am just anxious that as we go forward, and looking towards that 2020 reset that we anticipate we may have to confront, that we have ourselves well positioned so that all of our providers can continue to do the work. I'm going to go to Ms. Ellenberg for questions first, and then I'll have some questions. But one of the questions, Ms. Alvarado, that I'm going to have for you is, you know, you read the report and you think, gee, they used to get $3 million, now they get something like $12 million, plus some assistance along the way, and yet the relationship is getting tenser. What's that about? One would think that if you were actually serving, in some cases, fewer patients, as I read the report, if I read the numbers correctly, and receiving more funding, life would be good. That's certainly not the view I hear from the community clinics that I talk to. So I want to try and understand what is, for me, a bit of a disconnect. I also want to talk about, and this is what I love about a 15-page staff report, buried in every 15-page staff report, there are 3 or 4 words that should catch your attention. And in this case, it's intent to competitively procure agreements, which I found on page 14 of the 15-page document, which I think is staff report language for, we think it's time to go out and do an RFP for things that historically we haven't done an RFP for, which also I think has people a little bit anxious. So I definitely want to make sure we talk about that today. All right, with those perhaps somewhat provocative introductory comments, now I'll turn it over to Supervisor Ellenberg and see where she wants to go with it, and then I'll have some additional questions and comments myself. Supervisor?
Thank you, President Smitty, and I actually really appreciate your framing this as a conversation, because I do have a good number of questions. I am really delighted that there are, and appreciative that there are representatives from the community clinics here today. I think the conversation cannot be complete without their participation. So with no objection from you, I want to encourage you all to respond as well. But let me start, Renee, with a couple of things that you mentioned. You described the clinics as being incentivized to do this work, and let me ask a few together. Right. So I'm curious to know what that incentive is. And toward the end of your remarks, you noted that if they meet 80% of their goals, that's good, but if that means that they are paid 80%, one of the things that I'm struggling with is understanding how this business model works from the community health side. If they are paid after the services are provided, how do you run a business? How do you employ people, have some kind of expectation of consistency with this type of reimbursement? Let me start with that.
Yes, and as President Simitian caught, As you know, we had $3 million initially, historically, and then our board gave our clinics about another $3 million annually for 3 years. And so that makes it $6 million that was given as grants, essentially as county grants directly to the community clinics. The fundamental change that has evolved, and I call this an evolution of the partnership, quite honestly, to keep in line with both the policy trends that are going on nationally as well as in the state of California, is that instead of giving grants, all the payments are linked to very specific performance.
I understand that.
And so in this particular case, we realized that the clinics don't have the kind of infrastructure that VMC has. VMC has a much higher performance threshold under the waiver because they have to be improving year to year. So for example, if they're at 80% one year, they're expected to be at 85% the next year. And if they meet that target of 85, they're supposed to be at 90%. So it's a gradient factor.
I understand
for
how
VMC.
it works.
That's not the clinics.
Okay.
With the clinics is really based on a combination of both enrolling the uninsured under PCAP. So as long as they enroll, they get a per member per month rate associated with that. They also get payments associated with utilization, not quality, just strictly seeing patients. So that's where the incentive comes in, because one of the difficulties that we had in the 90s here in California is that many providers were getting the per member per month but never seeing patients. So the federal government learned about that, and they want to make sure that not only do we get the per member per month, but we actually are seeing patients. And then, of course, as a fact of seeing patients, that we're actually improving their health or at least addressing their illness. So there's some very specific
So
quality.
forgive me, is
Yes.
the PCAP enrollment tied to federal funding through the waiver?
We used a combination of things because it is. I mean, it's part of I think it's in the report. We initially had slated about $3 million to cover the other kids, undocumented kids that would not qualify under the Medi-Cal expansion. We actually fell short. It was the 300 to 400% of federal poverty level kids that were still out there, not necessarily qualifying for Medi-Cal or Cover California. We used a surplus out of that to cover the parents, essentially, of those kids, and to begin to do that PCAP specifically targeted. And I think in partnership with the clinics, we actually achieved that. 70% of the initial enrollees of PCAP were actually women. They were the moms of the kids that we're covering under Healthy Kids. So I think it was a good thing that we did this. And there was a per member per month payment linked to that piece using the general funds. What we've done under the new reimbursement model is we use that general fund in order to draw down and match and bring in federal dollars. Because these federal programs and initiatives, local entities like counties have to put up the local non-federal share. That is, Medicaid traditionally has been a 50-50 program, 50% federal, 50% state. The federal government has allowed counties that participated in the waiver to put up our own match and then be able to draw down the federal dollars.
I'm still struggling with the workable business model piece, and I appreciate the distinction that the hospitals have a much stronger infrastructure and much bigger workforce base. I think it was in Paul's report, there was a note including the hiring of community workers to support whole person implementation in the hospital clinics. Is that something we should be thinking about? Are you nodding, Tony? That we should be thinking about for our clinics as well, maybe a separate funding stream that allows them to build that capacity with whole person care or with to be able to provide the services that will earn them those points.
Right.
Is that something that might be separate from the performance aspect of the contract? That's one piece of what I'm thinking about. And if we've been changing a lot, it sounds like each year. Are you hearing, or let's hear from you directly, whether that is a challenging piece too? We want them to be sustainable. We want them to be partners. Clearly, they're providing a tremendous service in keeping folks out of the hospitals, out of the emergency rooms. But I'm from what I'm reading, I'm not feeling convinced that we're investing in a way that gives them the capacity to really do the work that we're asking them to do and to be successful. And at some point, we'll max out on PCAP enrollment, right?
Yes, the Measure A funding that was provided for 3 years, and we didn't dictate how they spent it. It was intended to prepare them to be medical homes. It was to invest in IT infrastructure and expand their care teams. The funding that's structured now is related to the service those care teams deliver. For example, they'll get the per member per month, and they could choose how to spend that per member per month.
Does that mean that they've completed the IT infrastructure build-up and have hired the additional people to provide the care?
So a slight, our perspective. Good afternoon, everyone. Thank you. And I do want to apologize for being late. Thank you for accommodating me.
We worked around.
Accommodating us. And CEOs are here. They can certainly answer your question in great detail. The $3 million, the Measure A money, which, as you know, is general fund, was used to prepare for the Medi-Cal expansion for the ACA, and things such as building extra exam rooms, purchasing dental chairs, etc. That's what that money was used for. So it was all infrastructure, physical enhancement of the physical plants. That was a big piece of it. So we knew that was one time. We knew that. Later on, as the new, what do you call it? Oh my gosh. Value-based revenue contracts started to get into place. That's when the change went from a grant that was used for operations to now value-based with different scope of work, different deliverables, and staffing patterns that not all the clinics had. And in one instance, what the clinic had to do was put out $500,000 of another pot of money to enable to get their team together to meet the deliverables of the new grant, of the new scope of work. So the answer to your question, if I understand it correctly, not all have been able to upgrade their staffing teams. We've done a lot of education, quality improvement education, but they have not been able to do that. And one of the reasons is the maximum financial obligation for each of the contracts is, in fact, as Renee said, several $1 million. That is true. If I look at how much revenue they've received up to February, or what they project to receive by the end of the year, if I'm looking at it now, there isn't one clinic that will be able to maximize that. So building a budget for the year based on an amount that is perhaps not attainable is very difficult then to go out and hire staff and then have to let them go at the end of the year. So it's a what do you call it, catch-22. Thank you, Alice. Thank you. Very difficult situation to be in. Now, because the clinics don't have the infrastructure and the support and basically the reserves that perhaps another agency such as the county has, then they're very cautious to ask for money up front. There was an opportunity to get 20 to 25% up front, but it wasn't free money. You have to earn it back, so you have to pay it back. Sure. And I can tell you for a fact that 2 of the clinics, or maybe 3, did not take the upfront money because they weren't sure if they were going to be able to pay it back, and then they'd get themselves in the hole even more. So that's the financial piece. And at your convenience, I have a couple other things I'd like to share.
I'd like to stay with Ms. Ellenberg's question on this piece, because I think it's the largest and most significant piece of this conversation. And thank you, Ms. Ellenberg, for letting me sneak in on your question here. I'm going to start from the premise that we want the community clinics to continue to exist and do the work that they do. I think that's a shared value.
Yes.
Then, in order for that to happen, they have to be economically viable. I don't think that's, subject to debate. And then the question is, what should that entail? And so where, the reason I perked up right away to Ms. Ellenberg's question is, the questions she's asking about, what is the basis for funding these clinics, it seems to me is the key question about whether or not the model is sustainable going forward. Now, there are a couple of possibilities, and I apologize if anybody gets a stiff back, but again, in the interest of a real conversation. So I heard Mr. Santiago, and it's been my understanding for a while, and the staff report lays it out, say, look, we have certain expectations of our partners, who are the clinics, and in order to make sure those expectations are realized, we have a contract, and in that contract, we set up a set of formulas that will provide payment to them, and some of the money they get based on bodies, and some of the money they get based on services. Right. That's my colloquial layman's version of what I heard, yes?
Correct.
Okay. So that raises some obvious questions. Are we using the right criteria to pay people? And the second part of that is, if we are using the right criteria, are we using the right metrics? Because we maybe say, you should be able to get 100 of those and we'll pay you this much money, when you can only get 50 of those or 20 of those. Or, as I say, maybe it's not the right criteria. Maybe we shouldn't be measuring those, whatever those are. We should be measuring this. But it seems to me there's sort of two different questions. One is, so are we measuring the right stuff? And then are our expectations in terms of quantitative metrics reasonable expectations? Now, the feedback I get from the clinics suggests to me that they think that we have an unrealistic set of expectations around metrics. Is that a fair statement, Ms. Alvarado, in terms of where the clinics are?
The fair statement, as I would put it, I hope.
Please.
Yeah, thank you, is the following. The devil's always in the details, and I know this is a policy group, and I hate to take you into the weeds a little bit, but if you bear with me for a second.
In layman's language, please, because if you start to walk us through the PCAP numbers and the W, then we're not going to get there.
We're not going to get anywhere.
Okay.
I'm not.
Please.
One of the asks that we have today is that we start the contract negotiation process yesterday. Because what happened last year, we started so late into the year and then there was a pressure to sign by September 30th. Otherwise, Renee would have to come back to the board, and we understand all that. Then folks signed, for fear of not having a contract. That's a fact. So what ended up happening is the metrics, the scope of work that you refer to, Supervisor, we did not give it the attention. We did not have the opportunity to give it the attention that it should be. Were these in fair metrics that could be met? Did it make sense? So we would like an opportunity to start this early, not only for this year, but really get together with Renee and his team and pull through a nice planning process that really looks at things strategically. What makes sense here? The one example, at one point, one clinic said, I can only see 100 patients. The contract came back with 350. So there was this back and forth. So thank you for letting me get into the weeds a little
right.
bit.
Before we get
that's what happened.
Before we get to the timing going forward, though, one of the points that you've raised in the letter you've shared with us is, the criteria themselves and the metrics that we're using. And it goes back again to what I think was Supervisor Ellenberg's sort of foundational question about what's the nature of these contracts. And so on the one hand, I've got, so it's me. It's on the one hand, you've got someone who is saying, here's our expectation around the criteria and the metrics. Then I've got the clinic saying, we don't now that we've signed these contracts, understanding, your recollection of the history, we don't think that the criteria or the metrics are necessarily fair or reasonable in terms of the cost of doing business and what it really looks like. Fair enough. By the same token, I've got to ask these folks, look, we pay money to the clinics for service delivery to make sure that people are covered, and that when they're covered, if they show up with a problem, their problem gets addressed. So it's hard for us as board members, I probably should only speak for myself, hard for me as a board member to get in the middle of that debate, because what I am struggling with is it that we've got the right criteria, wrong criteria or metrics, or is it that we're not getting what we pay for? Because neither of those is good. If we do the first piece, wrong criteria, wrong metrics, then you're not going to survive. If we've got the right criteria and the right metrics, and you're not delivering, and I don't mean that in an accusatory way, I just mean there's some tension between these two versions of what's going on in the world, then we have to say, why are you unable to deliver with the funding that is forthcoming? Now, I see you've got...
Do I have people behind me here?
You do. You got a hoverer.
Can I jump in?
And before we let the hoverer weigh in, let me go to Dr. Smith. And I will get us back, I promise, to this issue of where we go from here process-wise. But I think if we don't confront this fundamental tension now, starting another round of conversations without that fundamental tension being addressed is going to get us to a not good place. Dr. Smith.
Yeah, I wanted to weigh in a little bit because I thought the way you started the conversation was really a useful way, and I'd like us to hearken back to that, since I'm every day constantly confronted with somebody sitting at my desk asking for something and somebody sitting next to them saying, I already gave it to you, which is basically what's going on here. We want to make sure that the clinics are our partners. We want them to stay alive and healthy financially and operationally and keep their patients alive. They clearly are a value to the community, and they are value to all of our patients, whether we share them or don't share them. I think those are presumptions that you actually, were right on, and we need to keep that at the top of our list. Presumptions that are built into the system or have been built into the system for years that are never really expressed explicitly are wrong, and we need to get those out of the message. So yeah, I'm getting there. For example, there's been a belief that all of the clinics should be treated the same. They're all very different. They all have much different clientele, much different size, much different reserves, much different practices, much different stability, much different communities. They cannot be honestly treated the same and actually think that you're doing a good thing. They need different things. And so there has been built into the concept over the years, since well before you and I and everybody got here, that every time we changed a contract, every contract would basically be changed exactly the same way, and it'd be just a COLA every year, and that would be it. And that doesn't get the job done. We really need to have a much closer partnership with each clinic, realizing they all have different needs and different abilities and different responsibilities. That underlying misbelief also led to the belief that when we transitioned into a new model of pay for performance, which was required by the feds and the state, and which everybody agrees is a good model, that the same pay for performance model could work for everybody. It doesn't, because some of them have more access to certain types of patients that get paid for performance. Others have different types of patients that don't get paid for performance. So as you adroitly pointed out, Mr. Chair, you like that word, adroit? It's true that some of the money that was built into the current contracts was linked to performance and some wasn't, but the reality was that they weren't ever going to get up to their maximum financial unless there was the performance component built in. So in effect, it's all pay for performance, even though it's truly separate. But you don't have to do a whole lot for the first blob, but you're never going to get the second part without performing. And frankly, some of the clinics have a harder time performing than others. Some of them have more infrastructure, some don't. Some have more behavioral health, some don't. So I would argue since we're trying to have a thoughtful and useful discussion here, that we need to sort of go back to the drawing board at the staff level and rethink exactly what each clinic needs, and for want of a better term, use sort of a plan of correction model so that we see where it is that we can intervene as the, big brother, big sister, most effectively for those who need help, or for those who don't need help, see where we can stay out of the way. But it'll be on a case-by-case basis, and each one of them will have a different need set, and it won't be across the board the same kind of contract.
I want to insert a question that I don't want an answer to right away because I want folks to think about it a little bit. But after I insert my question without an answer immediately forthcoming, I want to go back to Supervisor Ellenberg's question or questions, because as I say, I think they really were foundational in terms of teeing this up. But my question is this, and I'm sharing this in part with my colleague on the board. If we go back to the drawing board, which I think has some merit, that will take us a long time. It's just a lot of work, and there's limited bandwidth in our own organization in terms of Mr. Santiago's time, your time, the time of other staff. So there is a question for these people, which is, if we all decided it was good to go back to the drawing board, how do we make sure things keep moving along and that folks are secure and that care is being provided in the intervening time period, whether that was 3 months, 6 months, a year, or 2 years or more? And so I just want to let that question linger for a minute, because that's because we're going to be in a new fiscal year here in a matter of 3 or 4 months. So Supervisor Ellenberg, thank you again, and I'll turn it back to you.
Thank you. You mentioned in going back to the drawing board with staff, are you talking just about county staff, or that's a process that you envision including the clinics in from the beginning? No,
everybody.
Good.
I mean, without trying to answer Supervisor Simitian's question, which I will not.
If you've lingered long enough, that feel free. That's okay.
We're always trying to build a new airplane while we're flying.
Yeah.
Luckily, we never crash, but we're always tempted to. I think we need to get everybody basically at the table and look at what are the strengths and weaknesses of each clinic individually, and where we can help, where we can't help, and basically remodel the contracts and the process in order to deal with those things. It's going to have to be a joint effort, and although you're absolutely right, it's going to take some time. I really don't think we have much other option, because we certainly don't want to, have a situation where the clinics are teetering on the verge of insolvency, nor do we want to have a situation where, we're just writing checks with no understanding of what's going on. So I think we have to do it. Whether it takes time and effort or not is really sort of not a question we can deal with. We just have to do it.
Supervisor Ellenberg.
Thank you. I really appreciate that. And the intervening question, which I think is echoing my colleagues, is what happens in the interim if this is not a 2-month process, but a 6-month or a 9-month process that takes us past fiscal 19 into 20. So that conversation I would hope would include an interim fix of what we do in between, and is the status quo appropriate? I don't want to get down into that level of it, but just being mindful of the fact that this may take a little bit of time to do it right and to do it in a meaningful way. So we need a stopgap piece as well.
Yes.
I think That's
Ms.
all I have.
Alvarado, Mr. Espinosa, the hovering presence there. Anything you want to share on this piece?
I think, first, I want to thank you, and I would like to thank Dr. Smith for capturing the essence of what my recommendation was or is our recommendation. I think that's a great step forward. There are a couple of other things that we're asking for in order to enhance the process, but I think that can be addressed through this process. So I appreciate that. That's what we wanted, that's what we need, and we've been waiting a long time to be at this table to ask you for that. So,
Well, before we go further, let me just confirm, I don't have any formal speaker cards yet on this item, and that's okay. No, truly, that's okay. We're really trying a slightly different conversational model here. So if Ms. Alvarado wants to stretch her legs for a minute or two and let somebody stretch their lungs for a minute or two, that's going to be fine. I do want to try and keep us on this issue, though, before we get to the other ancillary issues.
First of all, thank you for allowing me to speak, and I really appreciate Dr. Smith, providing guidance and an overview of where I think we're at. But just to give you a big picture, and hopefully quickly, so the clinic, and thank you, Renee, because Renee and Dr. Smith made an effort to give us more money, try to give us more money. The challenge is in the implementation, right? Because the clinics historically were used to getting 1/12 of their grant every month and could depend on it and could use it for operations. It wasn't for any targeted population, although because we have a lot of uninsured, used it for that most of the time. When the transition happened, it was based on populations of which the clinics may or may not have. Some clinics may have a lot of uninsured like us, some clinics may not. But the target populations were the uninsured and the high utilizing Medi-Cal. And then, same thing, some clinics may have a lot of high utilizing Medi-Cal patients and some may not, right? So the goals that were set, our effort was to, okay, every month we could count on, let's say, $10,000 during this 12-month period. But when it started rolling out, and if you didn't have the infrastructure, and that's what we're talking about, developing the infrastructure to capture the data, to capture the money, to capture all of that, if you don't have that in place, you're not going to be successful in at least achieving what you had in the past in order to operate. And that has been the dilemma. Some people are, like Dr. Smith said, some people have a capacity. Some people, for example, school health centers don't see a lot of high utilizing Medi-Cal populations because they're adults. Right? And some health centers, we see a lot of uninsured, a lot of centers don't see as many uninsured. So all I'm saying is that I think Dr. Smith hit the nail on the head. We're different, and we need different strategies to try to maximize. We loved it when you came to us and said, hey, we're going to be able to capture more money. The challenge is capturing the money, right? And so from the big picture, it's like working on getting people into PCAP. What is it going to take? Working with the other clinics to capture the GPP data. Gardner's at the forefront because we computerized it. It's with WPC, how do we create the opportunity to have case managers work with that population when you don't have any right now, and how do you pay for that? So those are all the factors that we're talking about in terms of this situation, and why because the clinics are saying, oh man, I used to get 1/12 and now I can't even get that, so I'm at risk from a viable perspective, and that's why we've had so much of a challenge.
Let me ask Dr. Smith and Mr. Santiago a question about this. We struggle here at the county, of course, with the fact that we do things on an annual fiscal year basis, which means that long-term thinking means next year. And that problem is aggravated by the fact that the climate at the state and national level are unsettled, to put it euphemistically. Having said that, Dr. Smith or Mr. Santiago or both, if we were going to take a step back and ask ourselves, all right, what are the sort of unique circumstances for each of these partners and try and address that, which I think is a lot of work, then would it be possible at the same time, mindful of these infrastructure variances, constraints, to sort of ask ourselves, what's a 5-year plan for the partnership? Again, understanding that the state and the feds toss us a curve fairly frequently, but a 5-year plan to sort of say, all right, what's this organization going to need to do over the next 5 years in terms of anything from electronic health records to training for their staff to, remodeling their facilities. I mean, so that we're not constantly, at least I'm feeling after 6 years back on the board, like we're sort of improv every year as we confront these. Dr. Smith, you got a thought on that? Is that possible? I shudder to use a phrase like a 5-year plan. It has a kind of a Soviet lingering feel to it, but it's not what I want to do.
No, it's a great question. I think we can give you sort of worst case scenario, hope scenario, and best case scenario kind of ideas. And we definitely should come up with a 5-year plan for our partnership. But we always have to put in the caveat that, things change so rapidly, particularly in healthcare, that the priorities, can intervene dramatically and change the direction rapidly. And, there's going to be a lot that we can't predict. And when you're talking about many partners in the soup, it's going to be dependent upon a lot of changes at the same time, because the clinics aren't the only outside partners. There's the family health plan, which does a lot of Medi-Cal managed care. There's also Anthem Blue Cross, which does some managed Medi-Cal care. There's the large IPAs, which contract with Family Health Plan, that also take away some managed Medi-Cal. So, we have a relatively constrained population, but a lot of different entities making different strategic choices. We can make ours, but they have to be able to be responsive to what the other choices are. So what you're asking for is a 5-year business plan, which is what I interpret you as saying, that for the partnership, we can give you our projections, but I wouldn't want to say that they could be super accurate. We can give you critical points, if this happens, that'll happen. If this happens, that'll happen.
You're being even more ambitious than I was. I'm more focused on sort of I'll pick a number, the 3 imperatives for the continued success of each of these clinics. So
we can do that.
I'm looking at Mr. Graham because he's sitting right in front of me. So, all right, Mayview. What are the 3 things they're going to need to do in the next 5 years to be successful, and what, if any, is our role in that endeavor? Or I'm looking at Mr. Espinosa, and I'm saying, all right, what does Gardner need to do over the next 5 years? And again, I don't know if it's remodel this space, train their people, do electronic health records differently, but like, what are the sort of the 3 things that if they're going to continue to be successful and they're going to continue to be our partners, and then, whatever that thing or things might be, okay, what's the way that we might assist in that if we think we appropriately should, or how are they going to go do it off on their own if we think that's the more appropriate way to go? I'm not talking about helping each one of them create a full-fledged business plan, but I sort of want to confront the looming challenges of each organization and say, could we be thinking about them more than year to year? Supervisor Ellenberg?
And you mentioned, Dr. Smith, the state and federal laws. So I think the overlay to all of this is compliance.
Right.
And what we have the flexibility and freedom to actually do differently, and what we are required to by law would, at least from my understanding, be a really important distinction to understand
yes,
what we can do, essentially.
Right.
All right. Dr. Smith, we are trying to get away from having endless reports at these meetings so that we can have just this kind of conversation. That being said, could we ask you or someone from your team to just sort of report back on where we are on these issues at our next meeting of this committee in April?
Sure.
And
Even if that conversation has been scheduled, that would be a great start.
yeah, as I said, it doesn't have to be, we're not asking for a 10-minute report, even just here's what the status is.
Okay.
Okay. And Ms. Alvarado, I know from looking at your materials in front of me, you've got a $52,000 contract. I'm going to suggest we not delve into that today. The other two recommendations go to the timing on starting the conversations, and so I'm hoping that today is the first day of the rest of our conversation, to paraphrase. And then the recommendation number 3 from you is to consider revising the reimbursement methodology and/or the scope of work. And I think that is obviously what we've been talking about and could and should be folded into these conversations, Dr. Smith, about the individual circumstances of each of the various clinic partners. Yes?
Yes. Can I indulge?
Indulge.
For a second? Since I'm starting my vacation today for a week, can I use this opportunity to ask Renee and Dolores to set up a meeting with all of the clinics and ourselves in my office when we get back in a week, so we can, Alice will be there obviously, and we can at least start drawing up the to-do list and find out exactly where we need to go.
And you'll have a fully rested CEO to be part of those conversations. What
Yeah.
could be better?
Thank you. We'll do that, and we'll get back to you and let you know how it's going.
All right. Then Supervisor Ellenberg, if you have additional comments or questions, this would be the time. Otherwise, time for a motion when your comments or questions are done to say receive report and to refer folks to our next meeting. But go right ahead at this point.
Thanks. I do realize that we want to move along and that you called out 3 of their recommendations to really focus on. Number 7 that we haven't talked about today is something that also really interested me. Consider allowing the WPC Community Health Centers who are providing services to HUMS patients the flexibility to refer directly. How does it work now? And if that's a long answer, I'm happy to take it off agenda, but do they have to go through the county to make a recommendation, to make a referral?
I presume that particular recommendation is related to the behavioral health, and I'm looking at Dolores because
To specialty mental health, to the
right,
through the
to
call
specialty
center.
mental health specifically. We have a partnership on the medical specialty, which is the e-consult. Very successful. We're nationally recognized for that piece, so I think there's already a referral path for the medical facilities and
Where
outpatient
we're
specialty.
talking about something
But the
slightly-
behavioral health is the
slightly
one that's
different.
actually needs to
So,
work.
no, for
Right.
example, if Gardner needs
Yeah.
to send a patient to their
Correct.
specialty care, they have to go through the call center, and they're not able to directly refer to their own or to another clinic. So it does merit further discussion, perhaps with
Sure,
with Tony
that's fine.
through you,
Yeah.
to see if that's something that would make sense.
We'll include Tony in that big discussion when Dr. Smith gets back refreshed. We'll all get around the
Wonderful.
table.
And I would like to get an off-agenda answer as to how the referral system works, what flexibility we have, and what the
Yes.
best practice is.
It's an old
Thank you.
system, by the way, that was created in order to create equity so that one person doesn't get all the referrals, et cetera, or one agency, I should say.
As with many ideas,
As with
there's a
many-
good
it was
gram, but is
idea,
it
a very
working?
good idea at the time.
Thank you. At this point, I would be very happy to move that we receive this report and incorporate the 2 requested follow-ups, the update meeting at the next meeting for all of us and the off-agenda report on specifically direct referrals.
Thank you. Any last word, Ms. Alvarado or team?
I do. I would like to take Alice, I would like to take you, Alice. I would like to thank Alice. She's been on board, 6, 7 months. Dramatic difference, because she does get into the weeds, which is often important. So thank you, Alice. Publicly, thank you for this. And thank you, the board, Dr. Smith.
Dr. Smith, anything else? Mr. Santiago? Okay. Then we have a motion by Ellenberg and a second by Semidian And without objection, I'll just say thank you, Supervisor Ellenberg, for reminding me that there was a page 4 to the letter. That was a helpful reminder. All those in favor, please say aye. Aye. Without any objection, passes unanimously. Thank you. Look forward to a fruitful conversation on a timely basis. All right, that takes us to item number 6, where we're going to get a report on integration of our system, our hospital integration report.
Thank you.
Mr. Lorenz, thank you.
Thank you, President Simitian, Supervisor Ellenberg. As staff come forward and take their seats, and I'll have the opportunity to introduce some key members at O'Connor Hospital and St. Louis Regional Hospital. I do believe, Supervisor Ellenberg, you had a question about how the yesterday went. What I'd like to do is ask Dr. Smith or Miguel Marquez to comment. I know that we had a successful management of the issue yesterday in terms of strike planning. It was a collective issue, not just, of course, the staff at Valley Medical Center, at O'Connor Hospital and St. Louis Regional Hospital, but also working closely with the county exec's office.
So I'll take the prerogative to say the good news and leave the other stuff for Miguel. Because we have such great administrative teams at O'Connor and St. Louis and great managers and great staff, they actually were able to keep both hospitals running very well. The doctors continued to provide quality, high quality, super quality care, and nurses also. The census was actually increased a little bit at both of the hospitals. The number of patients being seen in the emergency rooms went well. Surgeries went well. So from a patient perspective, a client perspective, I am told and believe that really it was all things going well and no significant problems. And they'll tell you differently if that's not true. But I think we had a great plan and did very well. The strike coordinator for the day was Miguel Marquez, my chief operating officer. I'll let him give you the details about the strike planning and how that went.
Thank you. I don't have a whole lot more to add because, as Dr. Smith said, he said the good news, and so there's only bad news left, and I don't think we had any bad news. I will say, and I want to just express gratitude to the whole county organization. We gathered at 5 a.m. at the Emergency Operations Center from folks throughout finance, FAF, all the different resources that we have. Everyone there bright and early at 5 a.m. Our mission was to protect, first and foremost, patient care and hospital operations, and that was done. And I think we also, working with security and everything else, gave the opportunity for the picketers to have their space to have, exercise their rights as well. And there were no disruptions. Everything went smoothly. We even had the opportunity to deactivate our Emergency Operations Center early at 10 p.m. Because the strike sort of over time reduced to the level that we didn't need the EOC anymore. So just gratitude for the excellent work that was done throughout, and again, grateful that for everybody in the county that we had no disruptions to either hospital operations or patient care that I'm aware of. Thank you.
Other comments, or Mr. Lorenz, you want to just pick it up from there?
Thank you. If I may take this opportunity to allow the leadership, first of all, from St. Louis Regional Hospital to introduce themselves, and then we'll go to your right, to O'Connor Hospital leadership.
Thank you, Paul, and thanks for having us. Gloria and I'll let Gloria introduce herself in a second. My name is John Henley. I'm the Chief Executive at St. Louis. I've been just about 20 years in healthcare leadership, 3 years at St. Louis, and really enjoy that community and the work that we're doing in Gilroy to serve South County. So excited to continue to move forward and grow what's happening down there. Gloria?
Good afternoon, everyone. My name is Gloria de la Merced. I'm the interim nurse executive at St. Louis, and I've been in healthcare for over 30 years and been working at St. Louis for the 19 years, and very excited to join the Santa Clara Health System. Thank you.
Manesh Bhamani. I'm an ER emergency room physician. I've been at O'Connor since 2006. So I've seen a lot of the changes that have occurred at O'Connor Hospital over the past 2 decades. I'm currently president of the, previous medical staff at O'Connor, now president of the Medical Leadership Council at O'Connor, and I'm looking forward to coming on as the local hospital executive. I'm actually quite excited about this acquisition by the county and the opportunity it brings for O'Connor Hospital and kind of the opportunity to resurrect and kind of grow O'Connor Hospital and provide care to the county, all of our county patients.
Ali Basiri, I'm the immediate past president at O'Connor Hospital and soon to be the chief physician strategist. I'll be helping Paul implement strategy and Dr. Smith implement strategy to grow forward with value-based medicine and all the current topics in vogue in medicine. Thank you.
Good afternoon. Juana Castillo, I'm the nurse executive at O'Connor Hospital, and I've been there 6 months now, and I specifically joined the team at O'Connor because I wanted to be part of transition, and I wanted to provide help and help the hospital. I have 19 years of healthcare experience, 15 of those in leadership, and I'm very excited to be part of this new journey as we move forward in a collaborative partnership. So I'm very happy to be here.
Hi, I'm Pat Wolfram, and I have been at O'Connor 3 years. I've been in the area, in the market, for 10 years. Before I came to O'Connor, I was at El Camino Hospital. My role is actually business development. So I came over to O'Connor because it was an opportunity to work with physicians and actually develop O'Connor because it was once a wonderful hospital. I enjoyed the physicians, working with the physicians. I enjoyed the staff. So I'm very excited about being in collaboration with SCC and actually having local governance help us grow our market.
Just want to welcome all of you. We're just thrilled that you're here, and it's great to meet you.
And I'm going to say just a little bit more than that. I think under circumstances like this, it is easy to feel like you're the kid brother or the kid sister in the organization, or the stepchild, or the junior partner. And I want to be very clear about the fact that I don't feel that way about what is now an integral part of the county operation. We got 2 million people in the county. I know I don't have to tell you, each and every one of them deserves top flight care and access to that care. Doesn't matter what end of the county they're in, although I'm a district supervisor and I'm occasionally heard to advocate for the needs of my district. But again, there are 2 million people here. They all deserve to be served well. And I don't care whether you've been part of the county organization for 15 years or 15 minutes. You're an equal partner in the endeavor, and I hope that you feel that way from day one, and that's the message that is communicated to you from every part of our county and from each and every one of your colleagues. So that was a long-winded welcome, so thank you. Back to you, Mr. Lorenz.
Thank you, Supervisor. And I just want to also just briefly comment before I get into some numbers and give you some specific updates. The team that you see here, along with the other leadership at Valley Medical Center, Jill Sproul, Benita McLaren, Teresa Fuentes from County Council, Phuong Nguyen. This collective group of individuals, Dr. Jennifer Tong, has been phenomenally stepping forward and making sure that the 2 priorities that you set for us have been met. The first of which I think we all appreciate, which was the seamless transition of care for our communities with these 2 hospitals. And I think that's been accomplished, and I'll share with you some of the numbers. The second part of this transition, which was critically important, without the staff at these 2 hospitals to provide the services, we would not be here today to share with you that there has been that seamless transition of care, quality care. And it is attributed to the people that you see before you, but the staff at each of the hospitals. So today we have at O'Connor Hospital onboarded 1,202 employees, professionals, and at St. Louis Hospital, 441. Now, we all realize that this is just the beginning, that we have a lot of work to do with regards to further recruitment and retention strategies to ensure that we are able to maintain a workforce that we can all be proud of. The next steps with regards to ensuring that is that we move staff from provisional status to permanency with county employment. County ESA has been working very closely with us, and we will be putting together a very clear plan to move forward to ensure the staff at each of these hospitals that they are valued and that we look forward to working with them long term. And that is a major part of making sure that we bring stability to these hospitals over the next several months. With respect to patient care, Dr. Smith had alluded to this, the census at the two hospitals remains steady, but in fact we're also seeing an increase. At St. Louis Hospital, they typically have averaged over the past 6 months of a census of 26, 27. They've been above 30, low 30s for quite some time now, actually not quite some time, since March 1st. And we see a steady increase in those service demands at St. Louis Hospital. At O'Connor Hospital, they've typically averaged a census of around 111. This was in the preceding 6 months. They are seeing about a 3 to 4% increase in the acute census, but we also have anywhere from 15 to 20 individuals in the hospital that are under observation status. They typically are in the hospital in that status because they don't quite meet acute level in terms of billing and collection, but they do require anywhere up to from 24 to 48 hours of care, depending on their clinical situation. So the demand in these hospitals and the services provided continue to remain not only steady, but we're seeing a growth in that demand. The emergency room departments at each of the hospitals, and you've seen these numbers before, but these are quite important numbers for me to reiterate. At St. Louis Hospital, they typically have a census of 90 patients per day. That number continues to gradually increase, and if they maintain that number, we will probably see close to a 10 to 15% increase in the total volumes on an annual basis at St. Louis Hospital. So the demand for services and the need for these hospitals is quite telling. With regards to O'Connor Hospital, 152 patients on average per day. Dr. Manesh Bamini can verify that, and they've been very busy over the past 13 days. And if they hold to those numbers, they could reach well over 50,000, close to 55,000 annual visits in their emergency room department. Collectively, as a system, including VMC, that's 500 patients seen in the emergency departments in our system on a daily basis, 500. And obviously those translate into obviously an increased census, but also our effort to meet the needs of the community for critical healthcare services. At this moment, we are working closely with the two leadership teams at both hospitals. Dr. Phuong Nguyen, Dr. Jennifer Tong are looking at ensuring that we have the appropriate medical clinical coverage at both facilities. As of March 1st, for example, we have neurosurgery coverage on a consistent basis at St. Louis Regional Hospital. We are working on podiatry, vascular surgery, pulmonary, GI, cardiology, and urology coverage at O'Connor Hospital, but also at St. Louis Hospital to ensure that when a patient arrives that they have the level of specialty care that they require and that it's consistent. With respect to the EHR, most of us have discussed this item at length in the importance of having a viable and strong electronic health record, both in terms of our clinical care, but also with respect to revenue cycle. We are in the process of doing workflow analysis, and we have a better understanding in terms of a go-live implementation date based on that assessment. We are looking at no later than August of this year for implementation. and we will keep this committee and the board apprised of our progress in that respect. And we are in the process of right now working with staff to ensure that we put the IT infrastructure in place to accommodate this technology and the software. From a finance revenue cycle, we've been making sure that on a daily basis that we have the charge capture and that we are accounting for all of not only the services but the related revenue that are associated with that interaction and that encounter. John Cookingham and his team are in the process of making sure that we provide to this committee and to the board regular accounts receivable performance on a go-forward basis, as well as a cash report in terms of our performance with respect to our revenue cycle. I'm very, very pleased that in many of the work streams that we have identified, and this also includes supply chain, that we have been successful in the transition and that we have a very clear path forward in terms of operations in each of these respective areas. So with that being said, I'd be happy to answer any questions, and I'm sure the team here would also participate in that if needed.
Supervisor Ellenberg?
Thank you for the report. I don't have questions this time.
Just a general question. All right, so the day came and went as well, if not better than could be expected. Everybody took a breath for, I don't know, 5-10 seconds. Now, looking ahead over the next 3 to 6 months, what's the biggest challenge that you're anticipating? I shouldn't even say the biggest challenge. What is it the thing we need to be sure we do over the next 3 to 6 months to make this integration a success is? This is a fill-in-the-blank question.
Stabilize the workforce by transitioning staff from provisional status to permanency with the county.
And that's important because?
That is important because without a stable workforce, a happy workforce, it would be very difficult for us to maintain this level of service. I believe John Hanley has a comment as well.
Yeah, just to add, there's still a level of uncertainty. Am I going to keep my job, or did the county simply acquire me for 6 months to make this transition? Not me, but my nursing staff, my techs. So getting through this process will be that affirmation that, yes, they're all on board.
Got it.
And will it take the full 6 months to do that?
We are currently working with ESA on a clear plan. Our hope is that beginning within the next 4 weeks, we will begin to have recruitment and appointments to permanent positions. And we will work through that over the next 6 to 9 months.
Yeah, and Paul, I apologize. I didn't mean to set 6 months as an expectation. Whatever that time frame is,
yes.
We're working through it.
Right.
I think it's helpful, frankly, for me to hear the comment because I think it would be easy, but apparently wrong, to say, well, the transition has occurred and people now work with us, and there we go. And what you're telling me is, or telling us is, yes, the transition has occurred and people still feel like they're in a period of transition. And at some point, that'll be a memory, and they'll be thinking they're part of an organization and looking forward rather than anxious about the moment on a day-to-day basis. Dr. Smith, I see your microphone is on.
I just wanted to augment a little bit when you're talking about the most important thing going forward. I totally agree that in a service organization like a hospital, a health system, the people, the employees are the most critical resource and the most important, person in the system is the patient. But without the employees being confident, happy, trusting, satisfied, challenged, enjoying their work, the whole thing falls apart. And these hospitals have been through an extremely difficult decade, actually more than a decade. It's been more like 20 years where there's been very challenging major issues to deal with, financial issues, changing ownership, changing management, changing patient populations, lots of changes constantly. But the employees and the doctors who work there all really love the job they do, and they love the facility and patients they take care of, and they're really committed to provide the best quality care they possibly can. So I think exactly in keeping with what Paul said, the most important thing for us to do as a county is to let them know that we're behind them 100% and that we're there to provide whatever support they need to get the job done. I have great faith and trust in the actual people, the employees and doctors doing the work. We just need to help them heal from the couple of decades of trauma that have occurred there. So that's what our job is from my perspective.
Thank you. All right, thank you very much. And I want to confirm with our clerk that we have no cards on this item. We do not. We'll say thank you to all of you for being here. I know you have other places to be and other work to do, so thank you for being here once again. And then in our somewhat back and forth format here today, we're going to go to 7C and pick up where we left off, and that will allow us to receive a verbal report from our health officer. Thank you all again for being here.
Wonderful. Good afternoon, President Simidian, Supervisor Ellenberg. I wanted to mention two public health items today, TB and tobacco. I'll start with TB because March 24th is World TB Day, and I just want to make sure that you know what the local situation is on the ground and that we have a lot of prevention opportunities to keep those TB patients out of our now large network of hospitals. First of all, World TB Day will be celebrated at O'Connor Hospital, no longer a community hospital, but one of ours, which I think is lovely. The TB incidence in Santa Clara County, which is the rate of new cases that we see each year, is actually one of the highest in the entire United States. So California has more TB than any other state in the nation, and then within California, Santa Clara County usually comes in about 3 or 4 behind just LA and San Diego. So that's translating to about 168 cases last year, but what you need to understand is that that's the tip of the iceberg, and then there's about 160,000 people that have latent TB, so that means they have an infection that's just really waiting to bloom into disease, which requires a lot of resources and a lot of care, so we have a lot of prevention opportunities. Supervisor Simidian, you had wanted us to talk about issues where we could use your help or a little bit of elbow grease or a little bit of push, and this is one of the reasons why I wanted to raise TB. And that's because there are 9 cities in the United States that get direct federal funding for TB prevention and control. In the state of California, those cities include Los Angeles, San Francisco, and San Diego, but Santa Clara County is not one of them. And that's despite the fact that we actually have more cases. So by the time you take our federal dollars, pass them through the state, get them to Santa Clara County, where we're actually doing the work of preventing and controlling TB, we receive somewhere between 38 and 43% as much federal funding per case as jurisdictions that are getting those direct funds. So this has been a problem for a number of years. We've pushed and gotten almost there, but not. Congressman Honda was helping us on this. It's still a significant problem. And so our county spends a lot of general fund on TB, where other cities get to spend federal dollars. So I wanted you to know that.
What's the magnitude? How much money are we talking about?
I don't have numbers, but I will be happy to get those for you. I just know the proportion.
Good. Thank you. And we will follow up. I see my staff is still here in the chambers. We'll work with both Mr. Margolin and with our folks at the Prime Policy Group, and then ask ourselves whether or not contact by members of our board to both members of our own delegation and or others that they may know might not be helpful. So to be continued.
Okay.
Thank you.
The second issue that I wanted to raise up for you is e-cigarettes. And the reason that I wanted to raise that up for you is I think you already know that it's a significant problem. But it's one of those where the federal government is not moving with alacrity, and we have a huge problem right now. So we don't have great local data, but we don't have any reason to suspect that our situation is significantly different than communities that have been surveyed, which show that in 2018, there is a 78% increase in e-cigarette use in high schoolers, 78% in 1 year, and it's still trending up. So that's over 20% of high schoolers using e-cigarettes. So why is that a problem? That is getting an entirely new generation of adolescents addicted to nicotine. So we've made huge progress in tobacco control, and now we have a whole generation getting addicted to nicotine. That's a huge public health problem. So a percentage of those and adolescents, very different brains, so very different to expose an adolescent brain to nicotine as opposed to an adult. And a portion of those who get the on-ramp to nicotine addiction through e-cigarettes will transition later to conventional cigarettes, and then you have a larger population that will end up in our network of county hospitals 10, 20, 30 years down the line. So our county, of course, has been really leaning forward in policies to try to prevent youth from accessing e-cigarettes. But most youth, so how can you get an e-cigarette? You can get it at a retail store, you can get it online, you can get it from a friend or family member, you can buy it from a friend or family member. What we're seeing is that increasingly youth, yes, they go to retail stores. Yes, we have a county ordinance where we have retail licensing where you're not supposed to sell to someone under 21, so that's where we can lean in. We can't do anything about internet sales. We need the federal government to become more aggressive. We need the FDA to become more aggressive if we're going to get ahead of this. So I wanted to flag that the FDA put out an announcement, some more draft guidance on e-cigarettes. It's great, but it's not nearly enough to leap us forward to where we need to be.
Thank you very much. Questions, or shall I go on to Valley Health Plan?
Two quick ones.
Please.
Thank you, Sarah, for the report. I appreciate that. Dr. Cody, I apologize. First, if you could send me information about the TB Awareness Day. O'Connor is in my district. I would very much like to be a part of that.
Be delighted.
And second, a lot of what my office is doing and talking about is empowering youth, and you may have met Christine before, but maybe connect with her around ways that my office can also support the e-cigarette work. And I also have lots of connections with school board members and school districts, and that might be a good avenue to help us expand awareness and education.
Yeah, I should have added that the local impact is that our TB prevention and our tobacco prevention and control program is getting a huge uptick in calls from schools who are trying to get some help to understand what to do and how to manage the increasing number of students who are using e-cigarettes during school.
Yeah. So if there are opportunities to work together, I'm very interested.
And I will just share before we move on to the next verbal report. I was also approached by a council member in Palo Alto, and their youth council is concerned about the issue and open to working on it as well. If there's a partnership there, I was pleased, obviously, to hear that the students themselves had generated an expression of concern, and they were working through their council member liaison on the issue. So if there's something we can do there in my district, happy to do it there or elsewhere around my district, around the county. All right, Valley Health Plan.
Thank you, Supervisor Simidian and Supervisor Ellenberg. I did not have anything to add to the director's report, but would be pleased to entertain any questions from the committee.
Okay. I think we'll say thank you, and then we'll go to the verbal report relating to the federal health policy and budget landscape, and I believe we look to Mr. Margolin for that. And if there's one place where there must be something to say, because there always is, what's happening at the state and federal level on healthcare policy, Mr. Margolin?
Thank you. I have a relatively brief report today, since there haven't been that many significant developments since I was with you last at the end of February. But on the federal side, the biggest development has been the release of the president's budget on Monday. It's important to note that this president's budget, like almost every president's budget, does not typically go very far in the congressional process. Elements of it may be enacted, but it's typically viewed as a preview of the administration's policies and values, and very little of a president's budget actually gets enacted. So it's important to keep that in mind as I discuss some of the key health elements in this year's budget. There's been a fair amount of attention paid to what has been described as a $1.5 trillion cut in the Medicaid program, very large cut described in many of the press accounts. The actual cut is smaller than that. It's still a terrifically large cut, but it's smaller than that because what the media focused on and what the president's budget highlighted was the end of the Medicaid expansion, the elimination of the Medicaid expansion, and they valued that at $1.5 trillion over 10 years. But the president's budget then says we're going to replace that Medicaid expansion with a new grant program that will provide about $1.2 trillion to the states. So $1.5 trillion cut, $1.2 trillion added in. That's really not as very good news, though, in the end, especially for California, because the new grant program they want to replace the Medicaid expansion with would discriminate against California and other states that have been aggressive in implementing the Affordable Care Act. The formula that they're suggesting is based heavily on the Graham-Cassidy bill at the end of the last Congress, the last effort to repeal the ACA. And that Graham-Cassidy formula would have shifted money away from California and sent it to non-expansion states. There was an estimate at the time of maybe $20 or $30 billion per year of lost revenue to California at the end of several years of implementation with this new very adverse formula. So you have the expansion dollars going away. You have also a proposal for a block grant or per capita cap, as was the case with Graham-Cassidy for the base Medi-Cal program. Again, that's very bad for California because it would only grow at the rate of the CPI, below the rate of medical inflation, and over time the amount of money available for the Medicaid program would significantly shrink. Again, this won't become law, but it's out there once again as an administration proposal. There also is an effort in the president's budget to implement a national work requirement for the Medicaid program, something I've talked about at past committee hearings. And again, we've talked about that as not being a concern here in California because in previous discussions, it's been a Medicaid waiver option that CMS has been encouraging. So if a state wants work requirements, they can pursue it, as Arkansas has. But of course, here in California, that's not something the Newsom administration would ever consider. Now, in this president's budget this year, they're saying we want to make it a requirement nationally, not a state option, not a matter of state flexibility. It's run somewhat counter to the larger administration rhetoric about state flexibility in the Medicaid program, because this item would be, in fact, a mandated requirement. And actually, Congressman Joe Kennedy, in an exchange yesterday with Secretary of Health and Human Services Azar before the Subcommittee on Health, chaired by Congresswoman Eshoo, had a back and forth about this exact issue. He asked the Secretary, why are you making this a mandatory requirement when in Arkansas we've just seen 3 or 4 months of experience with work requirements where nearly 20,000 Arkansas beneficiaries left the Medicaid rolls. They left the program. The program shrunk. And Congressman Kennedy asked Secretary Azar, do you know why that happened, what the dynamics were? And he said, we haven't had time to study that yet. And then Congressman Kennedy quickly followed up with the observation, well, if you haven't had time to study the demonstration project in Arkansas, why are you recommending this for the entire country? A very helpful and useful exchange. So there's also in the president's budget a new emphasis on HIV funding. In his State of the Union address, he talked about ending the HIV epidemic within a fixed number of years, making that a national priority. And there's $291 million in new HIV funding. That's all good. That's a positive development. At the same time, though, the president's budget cuts funding for international efforts to combat HIV by $1 billion over 3 years. So good that it's being funded domestically, not so good that $1 billion of international funding is being cut out if you're in fact committed to stopping HIV. There's also money for the opioid epidemic. That's positive, although the funding level is somewhat similar to what was in the budget last year. And if you describe this, as the administration does, as a national crisis, you would think that you'd want the funding to grow and not stay relatively flat. And the other irony here is when they also in the same budget call for the capping of the Medicaid program, they're capping the program and actually slashing the program because of that inflation rate restriction, slashing the program that treats 40% of all the individuals battling opioid addiction in the nation. So here's this major program to battle the addiction, and they want to cap the funding available for it, so that doesn't make a lot of sense. Couple last comments. Congresswoman Eshoo had a meeting of her House Subcommittee on Health and Environment yesterday. That's the one where Congressman Kennedy had a chance to cross-examine the Secretary. Congresswoman Eshoo pushed very hard, once again, on the theme of pre-existing conditions and the need to protect pre-existing conditions. She talked about how in the President's budget there are a number of proposals that would have the effect of weakening pre-existing condition protections. She also talked about the Texas lawsuit and challenged Secretary Azar for not defending pre-existing conditions in the Texas lawsuit. And she talked again about junk insurance and her focus on how dangerous selling junk. She calls short-term policies junk insurance. That's her shorthand term for it. She talked about the danger of allowing those policies to expand across the country. Last item I should report on is a state item, and that is that the opening for the position of Secretary of Health and Human Services was finally filled this last week by Governor Newsom. He selected Dr. Mark Galley to the position as his new cabinet secretary. Dr. Galley is a pediatrician by training, and this is good news for Santa Clara County because Dr. Galley is a veteran public health system leader. He spent the last several years in Los Angeles County as a top official in that system, working on whole person care. His title was Director for Community Health. Previously, he served as the medical director of one of the health centers in the San Francisco system. He's worked in both cities under the leadership of Dr. Mitch Katz, and he's very much a proponent of public hospital systems. So it's good news for us that he has this new position. He's very talented, very skilled individual. And that completes my report.
Thank you very much. Supervisor Ellenberg, any questions? Anyone else at the panel want to ask anything as long as we're here? No?
I just want to note that the HIV funds are not coming to Santa Clara County because the burden of our disease is not high enough. I was at a meeting with ASH and other big city health officials, and it was so nice to know that we're not receiving any of that money. I would also say that there's a big pot of opioid funds that was available for health departments by the CDC. We were initially told that we were eligible. We were getting together an application. The numbers looked funny to me. I either rightly or wrongly pushed back, and they withdrew our funding opportunity. They had the numbers wrong. So anyway, it's great there's funding, and it's unfortunate that much of it won't be coming here.
All right. I believe that brings us to the end of our meeting. Last call. Without objection and hearing none, we are adjourned. Thank you all very much.